Hi, everybody. My name is Monique Hill, and I wanted to welcome you to today's webinar on Do I Need IVF with TexasFertility.com. We are having a few technical difficulties, but if you can just hang tight with us, we're going to be right back, and we are just trying to get our presentation loaded so that we have all the information we need for you. In the meantime, if you'd like to check out what is on the schedule for future webinars, you can go to txfertility.com and go into the about information, and there's information on all kinds of webinars. And there's Dr. Hansard. So I will go ahead and introduce you to her, but if you just hang tight, we're going to go on hold for just a minute. In the meantime, also, I did want to let you know you will have an opportunity to ask questions during the webinar. There's a questions button. If you hit that, you can submit your questions. We'll be stopping halfway through and then again at the end to answer some of those questions for you. We'll get to as many questions as we can. I did want you to know that all of your information is confidential, so please don't worry about any of that being disclosed. So feel free to ask any questions that you're comfortable with. So if you will just hang tight, we are going to work on putting up the presentation, and we will be right back. Okay, I am back, and Dr. Hansard is back. All right, I think we're going to be able to make this work. Again, txfertility.com for future webinars. And feel free to ask questions. You can ask them at any time. You don't have to wait for us to break in between for those questions. And whenever Dr. Hansard's at a stopping point to answer some of those, then she will do so. And if you need me back on to ask those questions, if that helps you, we can do that. So I don't want to delay anymore. And here she is, Dr. Hansard.
Thank you. Here is this. Nope. Okay, I think this is finally where we want it to be. I'm here to answer questions and just to give you basic information about IVF. Monique, since this is on your screen, I'm going to have to tell you next slide. So, who needs IVF, and why would you be interested in talking about this or learning about this? This is looking at the information from Texas Fertility Center for 2018, giving all of the different factors that couples and individuals presented with for IVF. If you notice, the two most important ones or most common ones would be diminished ovarian reserve. We'll talk about what that means in a moment, and egg or embryo banking for future fertility. The other factors unexplained, someone needing to do genetic testing, recurrent miscarriage, endometriosis, male factor infertility is also very, very common, ovulatory dysfunctions, and tubal factors. Next slide, please. Monique, next slide, please. So the overview is going to be a look at pelvic anatomy, the impact of ovarian aging, lifestyle issues, the evaluation, the steps of the process, Embryo transfer genetic testing and then success rates. Next slide. This is an ovary. And in a normal ovulation cycle, we start with multiple early follicles, which throughout the next 2 weeks are in competition to become the dominant egg, which is the one that ovulates. Women start with hundreds of eggs in the competition to be the one that is able to release. And because of the way the brain produces the hormones that control ovulation, only one follicle ends up ovulating, and that's the dominant follicle. For IVF, that is not beneficial. We want many eggs to ovulate, and so therefore we are going to talk about what's involved in increasing the production and stimulation. Next slide, please. Most women don't know this, but the majority of the eggs that we were born with, the most eggs we ever had were when we were 20-week fetuses inside our mother's uteri. At that point, there was approximately 15 million eggs. By the time we're born, that number's down to about 1 million. And by the time we go through puberty, the number's closer to 400,000. Those eggs are depleted throughout the course of the normal menstrual cycle and aging. And by the time we go through menopause, all the eggs have been depleted. Next slide, please. In addition, as we utilize our eggs, as we age, the risk of those eggs that are remaining being abnormal increases. If you notice, the chance of a miscarriage is low when women are young. Up to the age of about 30, the risk of a miscarriage in any particular pregnancy is only about 10%. However, by the time women reach the age of 45, more than 50% of all pregnancies will be lost. That's because of the age of the egg and the result in abnormal embryos. Next slide, please. How do we determine what ovarian reserve is? This is a term that refers to quantity and often quality of the eggs that a woman has. We use a particular test that is comprehensive and looks at 5 different hormones involved in ovarian function. The results of these hormones are entered into a computer program, and a number is generated between 1 and 20. The higher the number, the better. This is referred to as an egg retrieval score, and it correlates to the number of eggs predicted to be retrieved if a woman undergoes ovarian stimulation. What we do know is that the FSH levels increase with decreasing ovarian reserve, and they can predict a poor outcome. The higher the level, the lower the egg count, and at levels greater than 18, there is a very, very low chance of having a successful pregnancy. Next slide, please. This slide demonstrates the impact that ovarian aging has, that FSH level have on success rates. If you notice, the red line is the young women under 35 years of age. Delivery rates are high when FSH levels are low. But no matter the age of the female, by the time that FSH level creeps up to 18, the chance of having a successful delivery is almost 0. Next slide, please. The next thing we look at in evaluating for IVF success rates and procedures is a semen analysis. With the semen analysis, we'll look at the volume of the ejaculate, the concentration of sperm per volume, the percent that have a normal appearance, and the percent that swim. Next slide. What about lifestyle issues? What can women do to improve their fertility outright, and certainly to improve their chances of success with in vitro fertilization? Next slide. Most of the guidelines are common sense. No smoking, no illicit drugs, a folic acid preparation, which most prenatal vitamins will have at least 400 micrograms, if not more, proper diet, Acupuncture is fine. A lot of women find it very, very useful for preparing for IVF. And exercise, there's really not any limitations on exercise. Next slide. So before we start IVF, there will be a basic fertility evaluation, looking at ovarian reserve, documenting whether or not a woman is ovulatory, looking at a semen analysis, if a male partner is going to be involved, doing an evaluation of the uterine cavity, and testing for infectious diseases such as hepatitis, HIV, etc. Other direction. Next slide. This is an HSG, a hysterosalpingogram, which shows a normal uterine cavity with open fallopian tubes. Next slide. Another way to evaluate the uterus is with a saline sonohysterogram, where saline is injected into the uterine cavity, and abnormalities such as an endometrial polyp can be evaluated. Next slide. Next. The stimulation process starts with a baseline sonogram to make sure that there are no cysts and that the antral follicles are normal. Next is gonadotropin information, which is what people refer to as the quote-unquote fertility drugs. Next, women undergo follicular monitoring with ultrasound and estradiol levels. These monitoring visits occur about every 3 days during the stimulation process, which lasts in total of 2 weeks. So a blood test and a sonogram help your physician determine if the dosage of medication is correct and whether or not changes need to be made. Next. After the follicles are completely mature based on their size and the estrogen level, a final injection called the trigger shot is administered to allow complete maturation of the eggs and prepare them for egg retrieval. Next slide. Next. The slide on your left, or the picture on your left, shows follicular development. Remember when we looked at the ovary first and we saw one dominant follicle? With IVF, we want a whole group of follicles to be growing and developing at the same time. On the left-hand picture, you see the follicles developing nicely, and they're all about the same size. Next. On the right, you see the uterine lining developing in preparation for implantation. Next. The egg retrieval is an outpatient procedure. Next. With IV sedation, next. It is performed exactly 36 hours after the trigger shot. It's done transvaginally under ultrasound guidance with IV sedation, with an anesthesiologist. Next, and it takes about 15 minutes to complete. This is the only day that women need to be, this is fine, leave it there. This is the only day that women need to be off of work. So the egg retrieval is done through the vagina with a needle that goes straight into the follicle. That needle is attached to a test tube and a suction apparatus that drains the fluid from the follicle. The egg is removed with the fluid that's in the follicle, sent to the IVF laboratory, and the embryologist will identify the egg at that point. Next. So what's typical for an IVF outcome? There is a strong level of attrition, and this is what happens even if pregnancies are conceived spontaneously. We start with a certain number of follicles. Let's say 12 to 14 is the average number that are retrieved. We may have 12 eggs out of those follicles. We expect about 75% of those eggs to fertilize normally, so 9 of 12. We may have of those anywhere between 30 to 50% that actually make it to a blastocyst, which is a pre-implantation embryo. And of that, only 1 or 2 of those embryos may be chromosomally normal and therefore available for transfer. Next. Pre-implantation genetic testing is something that has been available at Texas Fertility Center for many years. And this is basically looking to see if the embryo that we have has the right number of chromosomes and potentially if there are any genetic abnormalities within those embryos. The way to look at it is to say that the whole embryo is a book. Each embryo should have 46 chapters or 46 chromosomes. Each of those chromosomes is going to code for anywhere between, it's going to have at least 5 to 10,000 genes that code for a specific protein. So if the chromosome is the chapter, each of those genes are sentences, and base pairs are letters. We can go all the way down to a base pair to determine whether or not there's a genetic abnormality if we know what we're looking for. But most of the time when people say we're going to do PGT, what they mean is they're going to do chromosome screening. In other words, determine whether or not each embryo has the proper number of chromosomes. Next. If you look at success rates for tested versus untested embryos, there's quite a difference. In this slide, you'll see that the bottom line, the green line, is untested embryos and clinical pregnancy rates per age. In other words, women who are young, under 35, with untested embryos have about a 45% chance of becoming pregnant per transfer. Women who are 41, that number drops to about 15%. But if you look at the upper line, the red line, that's evaluating for embryos that have undergone chromosomal testing and have been shown to be normal. If you're under 35, the chance of having a chromosomally normal embryo result in a clinical pregnancy is about 70%. If you're 41 and have a chromosomally normal embryo, the chance of success is about 55%. Next. But what are the chances of having a day 5 embryo, a blastocyst that's chromosomally normal? The answer is it depends on your age. So if you look at the tan box, in women who are young, only about 35% of their embryos will be chromosomally abnormal. In women who are 35 to 39 years of age, that percentage rate creeps up to about 50% being abnormal. And women who are 40 and older, the probability of each embryo to be abnormal reaches 75%. That's important to know because when we talked about the miscarriage rates earlier, that was also tied to chromosomally abnormal embryos. So if you remember, women who are 45 who are able to become pregnant still have a greater than 50% chance of having a miscarriage. That's because the embryos are not healthy, chromosomally competent. Next slide, please. The embryo transfer is an outpatient procedure without anesthesia. It does occur at the surgery center in the operating room. A partner can be in the room with the transfer, and it's very similar to intrauterine insemination or like a pap smear. It takes about 10 minutes. Next slide. Most of the time these days, we do only frozen embryo transfer. It's rare to do a fresh transfer. Benefits of FET or frozen embryo transfer is that the pregnancy rates are higher, it's easier to schedule, it's easier to synchronize the embryo with the endometrium, and we can optimize the uterine environment. It eliminates some of the risks associated with a stimulation cycle called ovarian hyperstimulation, and the neonatal outcomes for the babies are actually higher and better with frozen embryos. Next slide. If you look at what percentages of transfers are using frozen embryos in our clinic, you can see that it's almost 100%. Blue is Texas Fertility Center, orange is the national average. And this is data from 2018 compiled by the CDC. Next. How do we prepare for an embryo transfer? Well, we can either develop the endometrium with estrogen, followed by progesterone that's either administered vaginally or by intramuscular injection, or we can stimulate the ovaries to ovulate and utilize ovulation to develop that endometrium to time the transfer and what the natural implantation window would be. And your physician will have their own preference for which preparation is most appropriate for you. Next. So how many embryos do we transfer? It varies. So in general, the answer is 1. If we have a chromosomally normal embryo, then we transfer 1 embryo only. If we have untested embryos, but a woman is under 35, we transfer 1 embryo only. Next slide. And why is that? The reason is because with multiple pregnancies, if we were to transfer 2 embryos and a twin pregnancy were to result from that, there are much higher pregnancy complications. Hypertension is twice as likely as a singleton gestation. Gestational diabetes is 1.5 times as likely. And almost all multiple pregnancies are delivered by cesarean section that carries its own risks. In addition, there are higher neonatal complications. Preterm delivery is 6 times as likely as with a single fetus. Neonatal intensive care unit admissions are 5 times as likely, and developing cerebral palsy in the fetus is 4 times as likely. This is why we want to avoid multiple pregnancies, if at all possible. Next slide. How does that look at Texas Fertility Center? Again, this data is 2018, and what you're seeing across the board is at least an 80%, if not higher, incidence of single embryo transfers in all of our patients. I would tell you with chromosomally tested embryos, which most of our patients are choosing to do now, that number approaches 100%. Next. This just shows you a schematic of an embryo transfer. It's done transvaginally through a catheter. We use ultrasound guidance so we can actually watch the transfer catheter as it goes into the uterus, and we can place the embryo about 1 centimeter from the very top of the uterus, which is where we would like implantation to occur. Next. This looks at pre-implantation genetic testing and what percentage of our transfers use PGT in 2018. This is based on 1,000 transfer cycles at Texas Fertility Center in 2018, compared to the national database of 163,854 transfer cycles. You can see that in Austin, a much higher percentage of patients are electing to do pre-implantation genetic testing of their embryos than the national average. Next. What is the percentage of transfers that result in live births? If you look at the national average compared to Texas Fertility Center, you can see that we are equivalent or higher across all age groups compared to the national average. And we run close to 50% for all ages up until 40. Now, this includes women who had genetic screening as well as women who did not have genetic screening in 2018. Next. This is a very busy slide. I put this up here only so that you know you can go to the CDC website, and if you just plug in CDC ART, which stands for Assisted Reproductive Technology, the fancy name for IVF, you'll be able to look at this kind of data for every IVF clinic that's a part of the Society for Assisted Reproductive Technology. What I will draw your attention to is if you look at let's see if it has it by transfer. If you look at the upper box, go down to percentage of transfers resulting in live births, and go across that. And then the next one, yes, percentage of transfers resulting in singleton live births. You can see that the discrepancy there would be the risk of multiples. When I tell you that we transfer only one embryo most of the time, what this doesn't account for is the risk, which is not insignificant, of that one embryo splitting into two. So we do see a higher incidence of identical twinning in IVF pregnancies. Another reason to be very, very cautious about transferring more than one. Next slide. Great. So what we'll do is we'll just go back to, that's the last slide I have. We can go back to, thank you, this slide of me. Hi. And I'm willing to and happy to take any questions that you all may have.
That was amazing. All right, let's see. We have a question. I missed the slide for what happens on egg retrieval dates, the details. Can you share that screen again? Oh, well, maybe you can talk to that.
I'll just talk about it. What happens on egg retrieval day? Was that the question, Monique?
Yes.
Okay. So basically, you will have known the 2 days before what day your egg retrieval is going to be. You'll get a phone call the evening of that trigger day to tell you exactly what the instructions are going to be, what time to take the trigger shot, and then what time to be at the ambulatory surgery center, last time you can eat or drink anything, what time to, and what to bring with you. This is a day when a partner, you'll need a driver because you're going to have an anesthesia. And that can be your partner or a friend or a family member. Once you arrive, you'll change clothes. The nurse will start your IV. They'll talk to the anesthesiologist about their part, the going to sleep part, and then we'll go back to the operating room together. From the time we get to the operating room until you're asleep is literally 5 minutes. This is IV sedation, so no tube down the throat, no ventilator, just asleep. The whole procedure itself is all done through the vagina, so there's no incisions, and it takes about 10 or 15 minutes. With this type of anesthesia, you wake up very, very quickly. You go back to the room you started in, the pre-op room, and finish your IV fluids. We keep all patients about an hour after an anesthetic just to make sure that there's not going to be any trouble with breathing or voiding, etc. And then you go home, you're done for the day. That's the only day that you're out of commission in this entire process and won't be working. Good question.
There's a question, how do you get this procedure done if your tubes were burned and tied?
So the fallopian tubes have nothing to do with IVF, which is awesome. That means that it doesn't matter if they were burned, tied, or removed surgically. We're going straight through the vagina into the ovary. So the tubes are completely out of the equation. Tubal factor with a previous tubal ligation or with tubes that have been removed because of an ectopic pregnancy or any other damage to the tube that results in its not functioning is one of the most common reasons for IVF. It's actually the reason that the very first IVF pregnancy and patient ever had this treatment done, Louise Brown in 1978. Had multiple ectopic pregnancies and had lost her fallopian tubes surgically as a result of that, and IVF was the only way for her to become pregnant. So that was the initial indication for this procedure.
That's great. One person asks, we're doing IVF due to male factory. All hormones, blood work are normal for me. Will I be heavily medicated during IVF or will it be modified for me?
So we use the egg retrieval score. We use that almost exclusively at TFC, but your doctor may just do a follicle count and look at an AMH level to try to determine what the starting dose is going to be. So he or she will look at your hormone evaluation as well as your age to determine what the appropriate dosage should be, or at least what the starting dose should be. And then you're going to have that follow-up ultrasound every 3 days or so for modification. We don't want to do this procedure for just a couple of eggs, because if you remember that inverted pyramid, we need quite a few eggs. Even with, a very healthy female, we need quite a few eggs to have a good chance of having 1 or 2 chromosomally normal embryos. So our goal is to get 10 to 15 eggs if possible. Some women can't produce that many. Some women will produce many more than that. So it will be custom tailored for you.
This may have been answered on one of your slides, but what is the success rate of IVF in women 37 to 39?
Well, fortunately, the 37 to 39 age range woman does almost as well as the under 35 in our hands. That was one of the categories that we looked at with the results. And if you looked at the national average, you saw that success rates started to drop off at the 37. And for TFC, we're actually just as high in the 37 to 39 as we are in the 35 and under. And that may be because more women in that age group are choosing to do genetic screening of embryos. It may be, the stimulation protocols or embryo development, but that's something that we're very, very proud of.
That's great. Does endometriosis prevent IVF from being successful?
Great question. It doesn't. So I didn't show the slide because I couldn't find this comparative data for the more recent CDC that I was looking through today. And the reason that the data that I presented is 2018 is because it always stays behind by a couple of years. We have to report our live birth data. So even if someone finished IVF in 2019, their baby wouldn't have been born until 2020. And then they use 2021 to compile the data, audit it, and have it ready for publication. I think we may be delayed a little bit because the CDC's been busy this year, as everyone knows. So they've had their attention drawn elsewhere. So we're not really sure what's going to happen with this data presentation in the near future. But one of the slides that they typically have, or one of the ways that they break down the data, is looking at the different diagnostic criteria and comparing the success rates across the board. So in other words, unexplained infertility compared to endometriosis, compared to male factor infertility, compared to diminished ovarian reserve, compared to uterine factor. And across the board, the statistics are very, very similar, with the exception of diminished ovarian reserve and uterine factor, which both have lower chances of success. So IVF is really one of the best treatments for fertility for endometriosis patients. Long answer to a short question.
Great news, though. Great news. Is pregnancy resulting from IVF a greater or lesser risk of miscarriage?
In our hands, it's actually lower risk of miscarriage because so many of these embryos have been screened. And the risk of miscarriage with a chromosomally normal embryo is only about 5% versus the risk of miscarriage in that one of those early slides we looked at, which in our patients' age usually varies anywhere from 25 to 50%. So IVF helps because we're already pre-selecting embryos that at least, even if we didn't do the genetic screening or chromosomal screening of, we've at least chosen embryos that have the morphologic appearance of a viable embryo. So it gives it a better chance of being successful from the beginning.
One thing I love about these webinars is being able to ask questions without having to actually go to a doctor's office. This one's pretty personal. I have thyroid nodule benign and breast hyperplasia. Would that be of concern towards IVF, and would IVF be harmful to that?
For a thyroid nodule and breast hyperplasia, no. So as you know, we would probably recommend that the thyroid function be well controlled. If the nodule is related to a condition like Hashimoto's thyroiditis, and being followed by an endocrinologist, we would make sure that the dosage of thyroid replacement hormone was adequate. And if there was any concern for abnormal structure in breast tissue, we would recommend a mammogram prior to starting stimulation or ultrasound evaluation of the breast.
You know, there are a lot of questions about fresh eggs versus frozen eggs. So this one is
Okay, for eggs. Okay.
If you froze eggs, can you use those eggs first? What's the attrition rate on frozen eggs? Or do you prefer to use fresh eggs? Also,
I'm
do you
sorry.
have to fertilize all the eggs? We don't want a lot of extra embryos.
Okay, so this is a pretty common question. Fresh is usually preferable, but we have very, very good success rate with frozen. The problem is that when it's an egg that's been frozen, we have no idea how it's going to perform until it's exposed to sperm. So when we see women who are trying to decide about, for instance, fertility preservation and delayed childbearing and egg versus embryo banking, if there's a male partner involved, it's always better to bank embryos because they've been exposed to sperm and we see how they do. A lot of our patients who freeze eggs and then later come back to try to get pregnant say, you know, should I use my frozen eggs first? And I tend to, and I think my partners would agree with this, if at the time that you return to try to become pregnant, you still have reasonable fertility function or fertility testing, it makes more sense to try to conceive on your own before using the frozen eggs, and then keep those as an insurance policy or a backup plan for the second or third baby. You know, if you froze them when you were 34 or 5, and now you're 37 and you want to be pregnant, but you think you might want more than one baby, go ahead and try to get pregnant with your eggs now and keep those 34-year-old eggs in your back pocket for when you're 40 and want to have another baby and it's not working out well.
You're getting a lot of questions. This is a great topic. For us, we got pregnant easily with our first, but have since learned we both have recessive carriers for genetic disease. We're considering IVF for PGD testing. Does that drastically change the number of eggs you'd want to retrieve with the attrition, et cetera?
It all depends on your age. So it's, you know, you're really only looking at statistically a 25% chance of embryos being completely affected with whatever that disease is. 25% should be not affected at all, not even carriers, and 50% would be carriers. So yes, it does increase the chance or increase the number of eggs that we want to have to work with, because we know we're going to have a certain percentage that will not be available for transfer that will carry 2 copies of the gene. And when we do you said PGD, which is what we used to call it. We call it PGTM now, pre-implantation genetic testing for mutation. We almost always do aneuploidy screening too, because what you don't want to do is transfer an embryo that doesn't have 2 copies of the gene, but has a significant chromosomal abnormality. So what we're shooting for in your particular situation would be embryos that are not only chromosomally normal, but also don't have 2 copies of the mutated gene in question.
Is diminished ovarian reserve diagnosed based on AMH levels? And if so, at what level?
Well, there's not a specific level, but when I was talking about this test that we use that looks at these 5 different hormones, the reason we like it so much and lean so heavily on it is that not only will it tell us the AMH is part of that, and that is one of the factors that we use in determining ovarian reserve, but it will also tell us, compared to your age cohort, where do you fall? So are you average? Are you below average? Are you above average? So how do we determine diminished ovarian reserve for your age group? Really depends on what your score is relative to other women in your age category. In general, a level of 1 or greater is considered normal, But if you're 22 years old and AMH level of 1 is low, if you're 45 years old and AMH level of 1 is like, that's pretty good for 45. So it all depends on your age cohort and what we assume, what we would assume would be normal. AMH is a number that decreases over time as the egg supply diminishes.
How does PCOS affect IVF, or is it even an option?
It's absolutely an option. So there are some concerns that women who have PCOS have lower success rates with IVF. That's not necessarily something that we see. That's another one of those diagnostic categories that is statistically similar to endometriosis or male factor or unexplained infertility. The silver lining for women with PCOS is that they tend to have a higher than average AMH level compared to other women in their age group. So their egg count is greater. And PCOS is one of the more common reasons that IVF is chosen.
Let me see. Is the thyroid level, TSH, does it need to be less than 2.5 for pregnancy? Is 3 to 3.5 normal?
3 to 3.5 is normal, but not ideal for someone who wants to be pregnant. And this has nothing to do with miscarriage rates or success rates, but the data that's looked at TSH and how it correlates with fetal outcome is really more associated with the neurologic development of the fetus. So a TSH level of 2.5 or less is associated with better neonatal outcomes.
Let's see. I have left hydrosalpinx, I may be saying that wrong, and my OB/GYN told me that I would need my left fallopian tube removed before IVF because it's embryotoxic. Do I need to remove my left fallopian tube before or after egg retrieval?
It doesn't really matter when the fallopian tube is removed relative to the egg retrieval, but I completely agree that it needs to be removed prior to the embryo transfer. The reason is because that fluid, the fluid that collects in that fallopian tube is full of dead cells, old blood, and that actually has communication to the uterine cavity. So the concern is that that fluid can backflow into the uterine cavity and really change the environment for implantation. So that's the reason to remove it prior to embryo transfer, but it will not affect stimulation for egg retrieval.
All right, do you have time for maybe 2 more questions?
Sure.
Okay.
Shoot. On a roll.
I keep testing positive for HPV and I'm 44. How hard would it be for me to get pregnant?
Unrelated.
Unrelated, okay.
Completely unrelated. It would be hard to get pregnant at 44 because of being 44, not because of HPV.
For someone that has unexplained infertility, how many IUI would you recommend before jumping into IVF?
Typically not more than 3 or 4. So that's based on statistics that show that couples who conceive spontaneously, about 50% are pregnant within the first 3 cycles of not using contraception, about 75% within the first 6 cycles. And the concern with unexplained infertility is that there really is an issue that just can't be diagnosed until you get to IVF. And some of those issues would be poor fertilization capability, poor embryo development, and just overall poor egg quality. Those aren't things that you can see or diagnose without IVF.
All right, last question.
Okay.
Is an egg retrieval score of 5 too low for a 38-year-old to consider IVF? What kind of success results can we expect?
I'm sorry, can you repeat that question?
Yeah,
Cut
sorry.
out for a second.
Is an egg retrieval score of 5 too low for a 38-year-old to consider IVF? What kind of success results can we expect?
Got it. Okay, so the egg retrieval score goes back to that testing that I was talking about that gives us a number between 1 and 20, and the higher the number, the better. An ERS of 5 is in a 38-year-old is going to be below average. But I think that, if you could get 5 eggs, which is really kind of the estimate that the hormones would suggest, I think that what would happen is your physician would probably be very aggressive with the dosage of medication and the stimulation protocol to try to maximize your response. If you could get 5 eggs, have 4 fertilize, have 1 or 2 make it to blastocyst, you got a chance. The question is, what's the alternative? Either you keep trying what you're doing, or you say, if we're going to do IVF, maybe I need to consider using an egg donor. I think most people would give IVF a shot before resorting to that.
Let's see. Okay, one more popped in.
Okay.
What are some side effects of IVF medications?
Well, the most significant side effect is a condition called ovarian hyperstimulation syndrome, where the ovaries get really large and the estrogen level is high. This is seen much more commonly in women who are really young, or women who have a very high AMH level or ovarian reserve, or women with polycystic ovarian syndrome. We can mitigate these risks and side effects by changing the way that the trigger is administered or changing the medication that we use, in addition to using another medicine called cabergoline, which decreases the severity and incidence of OHSS. So that's one of the things we're looking for with all of that monitoring that happens every 3 days with the sonograms and the estrogen, is really trying to protect women from these kind of abnormal and potentially significant side effects.
Well, thank you so much, Dr. Hansard.
You,
that was amazing. It was great information. And I neglected to tell everybody that the next seminar is June 17th, and it's discussing male infertility. So
wonderful.
Yes. So men join, and ladies, bring your husbands or your partners and join us again. Thank you so much for your time. That was really great.
The last thing I just want to say is there's a lot more information and even a recap of some of these slides on our website at TX Fertility, www.txfertility.com. So check it out and reach out to us if there's any other questions.
Thank you so much.
All right. Thank you.
Bye.
Everyone have a good night. Bye-bye.